welcome to this Prasiska Breast Mini Tumor Board on breast cancer. My name is Dr. Reshma Matani, and I'm a breast medical oncologist and an associate professor of medicine at Sylvester Cancer Center, University of Miami, where I co-lead the breast cancer program. It's my good fortune today to be joined by several well-renowned experts in breast cancer, who I will now ask to introduce themselves. Dr. Buchholz.
Hi, my name is Tom Buchholz. I'm a radiation oncologist, professor emeritus at MD Anderson Cancer Center in Houston. I'm the medical director of Scripps MD Anderson Center in San Diego.
Terry Bauman is a breast surgical oncologist. I direct the breast cancer program at the Orlando Health Cancer Institute.
Hi, Bill Gradisher, professor of medicine and chief of HEMONC at Northwestern University in Chicago.
Hi, I'm Maxine Jockelson. I'm a breast imager at Memorial Sloan Kettering Cancer Center, professor of radiology, and I also do a little bit of PET.
This is a 75-year-old woman with a history of stable lung cancer, PT2N1 left breast carcinoma, diagnosed in 1994, treated with breast conserving therapy, and let's also assume that she received radiation, post-lumpectomy radiation, although it's not stated on the slide, and left axillary lymph node dissection, followed by adjuvant cyclophosphamide, methotrexate, fluorouracil. And in 2016, in the contralateral breast, a PT1C-N0 right breast cancer is treated again with breast conserving therapy and again post-lumpectomy radiation, although not stated on the slide, and an unsuccessful attempt at letrozole. She now has a locally recurrent left-sided grade 2 invasive ductal carcinoma, ER and PR positive, HER2 negative, and recently underwent a left total mastectomy where a positive inferior superficial margin was noted. Again, detailing the patient's presentation, most recently, she palpates a lump in her left breast that was, and when she presented for a routine chest CT for lung cancer follow-up, and we'll assume that that lung cancer was an early stage lung cancer and she's been rendered cured of that. Her performance status is 0. In terms of her other medical conditions, other than the lung cancer, she has osteopenia, hypothyroidism, hyperlipidemia, and gastroesophageal reflux disease, or GERD. Her gynecologic history, she had menopause at 48, gravida 2, para 1, no breastfeeding or hormone replacement. She uses no tobacco or drugs and drinks 1 alcoholic beverage daily, and has a family history of ovarian cancer in her maternal grandmother, but no history of breast cancer. In 1994, these are the details on that left-sided breast carcinoma. It was a T2N1 tumor treated with breast conserving therapy, post-lumpectomy radiation, and adjuvant CMF. 2016, the right breast cancer is a T1C-N0 tumor, again, breast conserving therapy, post-lumpectomy radiation, and an unsuccessful attempt at letrozole. And then in January of this year, she palpates that left breast lump, and the chest CT shows post-surgical changes in the left lung and bilateral breasts with a slowly growing nodule in the inferior medial left breast.
The single slice of her chest CT is shown here, and you can see in the medial portion of her left breast there is a discrete nodule, and nothing on the right breast.
In January of 2020, a bilateral diagnostic mammogram shows the left breast with post-surgical changes and a questionable asymmetry in the inferior aspect. By ultrasound, this lesion is 6 by 5 by 7 millimeters at 8 o'clock, 6 centimeters from the nipple, and an ultrasound-guided core biopsy confirms grade 2 invasive ductal carcinoma, ER positive, HER2 negative. She undergoes a mastectomy in March of this year, and there are 2 separate findings of tumor. One is an invasive ductal carcinoma, ER/PR positive, HER2 negative, and a larger focus of involvement with invasive lobular carcinoma, ER and PR positive, HER2 negative. The invasive ductal carcinoma is present on ink at the superior inferior margin.
So there is a single view of her breast ultrasound that I assume was performed to work up the chest CT. I don't have the mammogram that was performed. And you can see in the 8 o'clock axis, 6 centimeters from the nipple, there is an irregular hypoechoic mass, which again is it's sub-centimeter in size and certainly looks like it corresponds to the finding on CT. In terms of the lobular cancer that was larger, I didn't see the mammograms, but we all know that invasive lobulars, even when that large, can be missed because they grow in lines rather than develop masses.
So the question, let's address this question first regarding the positive margin post-mastectomy in a patient who initially underwent left breast conserving therapy and radiation. And now the question is posed as regarding re-irradiation is phrased as because she couldn't tolerate anti-estrogen therapy. But Dr. Buchholz, would you consider re-irradiation in this situation regardless of her tolerance to hormonal therapy?
I don't think that would be my first choice. I think I would pull Dr. Mamounis into the conversation and try to recreate exactly where this margin is and what's its relationship. She likely, given the very long interval from 1994 to 2021, she likely has developed kind of new breast cancers rather than true recurrences. So here's someone probably who has had a history of 4 breast cancers now over the course of her time. And mastectomy is a highly effective treatment for early stage breast cancers without the need for radiation. So if it were a possibility to not re-irradiate this tissue and do more of a surgical taking care of the margins, if we could localize where anatomically these margins are and perhaps do a re-excision, that would be my preference, and then consider no radiation in this setting. Sometimes you know, on highly aggressive local regional recurrences or chest wall recurrences after post-mastectomy radiation, those people are really high risk of subsequent, and sometimes we could consider re-irradiation. There's a long interval history, again, allows for repair. We could keep the dose very superficial and try to stay off the chest wall and minimize the risk of a real serious complication like chest wall necrosis. For this particular case, I'm hoping we don't even have to entertain some of those potential toxicities associated with re-irradiation.
Dr. Mamounis, do you agree that you would try to go after this involved margin to identify where exactly it is? And also, I'll ask you as a follow-up how you would handle the nodal assessment. She had an axillary lymph node dissection on the left back in 1994.
Right, so yeah, I would agree. I would go back to the pathologist and identify exactly, sort of, if possible, where the margin is. If there's a mastectomy and they have the nipple and the skin, they may give me an idea, even centimeter wise, how much it is. It appears to be the superficial inferior margin, so I would focus more in the inferior flap of the mastectomy. Usually the mastectomy will go all the way medially if it's a total mastectomy. So I would probably then re-excise the inferior skin margin, essentially to probably a couple centimeter area, assuming what the pathologist can tell me. And I agree that that's a better option, I think, for this patient, because if you looked at the tumor on the imaging, it was fairly close to the skin. So even with a mastectomy, you know, the margin could have been positive, but I would remove more skin, and it appears again to be on the inferior side of the mastectomy. So I will focus on the inferior flap. Relative to reoperative assessment of the axilla in patients with recurrence, typically it can be done. In other words, reoperative sentinel lymph node biopsy can be attempted. After excised dissection, you probably have about 50% chance of identifying another sentinel node. And given also the medial location of this tumor, it may not even be in the axilla, could be in the internal mammary. So I typically am a little less enthusiastic about offering lymphatic mapping and sentinel lymph node biopsy after excised dissection. if they had a prior sentinel lymph node biopsy, the data suggests that you may find another sentinel node in about 80% of the times or so. So that is something that I would propose and do. I'm again less enthusiastic about doing it. And in this case, it wasn't done. I don't think I would, go back and do it afterwards.
Okay, thank you. Dr. Gradishar, given this patient's age and her prior history of lung cancer, the decisions about chemo are somewhat easier. But if she were younger, is this a patient you would be considering for more chemotherapy in the setting of a local recurrence?
Well, I guess that's the debate. And she's how old now? Just
75.
Yeah,
with-
75. So, you would have to be, the obvious right now, we wouldn't be overly enthusiastic about treating her with chemotherapy. We'd have to have a pretty compelling reason to make the case for that. If she were much younger, again, of course, we always have to weigh her risk of recurrence from her other cancer. And in this case, it seems like she's gone a while without any issues. So the hope is that she is cured from that disease. The interval that was from her first breast cancer till this event, as others have suggested, raises the issue of whether it's a new primary. And if the patient was postmenopausal, I would even if she was not, I would consider doing, a molecular test to make a case for whether or not chemotherapy would be considered. Again, I wouldn't be looking for a reason to give her chemo. I'd be more inclined to find a reason not to give her chemo. And it may be because Terry is not overly enthusiastic about resampling the lymph nodes, that if you happen to have a molecular test like the recurrent score that was low, you wouldn't really care because you're not going to give her chemotherapy. And I do think that though she didn't tolerate, it's not entirely clear the story, but she did not tolerate prior endocrine therapy. It is something, if she was in good health otherwise, that I would consider at least revisiting that question of whether she could try it again and see if she could tolerate it.
How do you approach this issue with intolerance to hormonal therapy? When she was treated for that right-sided cancer in 2016, she was placed on an aromatase inhibitor. And she's 75. Do you have any concerns about perhaps offering her tamoxifen given her age and the clotting risks?
Yeah, so I think we have to weigh those kind of considerations in older patients as well as take into account their prior history, whether they have clots or other comorbidities. I would also not dismiss the possibility of trying a different AI. I think you and I in particular know that although there's no good reason, sometimes patients tolerate one versus the other, even though we'll tell them at face value they have equal efficacy and very similar toxicity profiles. But every once in a while, somebody responds better or tolerates one better than the other. So I wouldn't discount the possibility of trying. I think she was offered letrozole, didn't tolerate it, exemestane or anastrozole. And, again, if those failed, I would maybe, even consider tamoxifen in her despite her age.
So before we move from this case, I'll just ask you all, as we think of patients and their potential for genetic testing, we often don't think of testing these older patients, but here this 75-year-old woman has had bilateral breast cancers that are ER positive. She has a family history of ovarian cancer. Is there any indication to put her through genetic testing? Does anyone feel strongly?
I think so. I think it's very reasonable. Like I said, she potentially could have a history of 4 cancers if you count the 2 cancers within the current mastectomy as separate lesions. So clearly she's demonstrated a phenotype that says she has predisposition to the development of cancers. It might be of useful information for her children and grandchildren down the road.
If I'm not mistaken, it was in the first cancer in 1994.
Yes.
But she was 49 at the time.
Right.
48. So yeah, definitely.
Yeah, very reasonable.
I agree.
Okay, So to summarize this case, the panel concludes no re-irradiation. Instead, try to localize where that involved margin is, focusing on the inferior skin margin. As far as lymph node evaluation, although sentinel lymph node could be attempted, given the medial location of the tumor, that node may be in the internal mammary region. We're less enthusiastic and wouldn't go back in this situation to do a sentinel lymph node. Given the disease-free interval, this raises the question, this could be a new primary. We could consider genomic assays to help make a decision about chemotherapy, and would certainly consider re-challenging with a trial of hormonal therapy, and finally a recommendation for genetic testing in this patient with a history of multiple cancers. So the next few slides are basically variations on these themes on this theme of a local regional recurrence. So let's discuss the situation of a patient that had a left breast recurrence. And in this situation, if it had been 2.2 centimeter invasive carcinoma with surrounding DCIS, ductal carcinoma in situ, within a 0.1 centimeter of the margin on lumpectomy and sentinel node biopsy, would radiation be adequate therapy, or does the patient require a mastectomy even if breast conservation is desired? Dr. Maminas, I'll ask you to take a stab at this question.
Yeah, and obviously I'll let Dr. Bajos chime in on that as well, but certainly sort of the book answer is that after in breast recurrence, mastectomy is the sort of standard of care. However, we have attempted and successfully treated many patients with repeat breast conservation, and now we have even prospective trials to that, but also several retrospective looks to say that if you can resect with negative margins and do limited radiotherapy to the breast, the local control is pretty good. I mean, there's still subsequent local recurrence rate, but in general, a little higher actually than in the older studies, about 15 to 20%. But certainly you can do it, particularly if you think it is a second primary, like in this case. So yeah, I would be able to, in particular with the 0.1 centimeter margin, I would be inclined to say that this patient could benefit from radiation, but I'll let Tom weigh in on that.
So I would agree with what Dr. Maminas says, that the standard of care for someone who develops an in-breast recurrence following prior lumpectomy and whole breast radiation would be to proceed with mastectomy. I also agree that it's reasonable in counseling the patients that if they strongly desire breast conservation, to do a second lumpectomy as long as it's cosmetically acceptable to the patient after her first lumpectomy, and follow with partial breast radiation is a strategy that's can be done safely, and early data suggests that it has some efficacy. Whether or not to re-excise the DCIS with 1 millimeter prior to doing is another topic, and I guess if the patient, it's really a cosmetic choice, it would be preferable, if we're going to do everything to minimize the risk of a subsequent breast recurrence, to re-excise that DCIS margin, unless it comes at too great of cosmetic cost. If it does, with her history of already 2 breast surgeries, then yes, we could just treat that with escalated doses of localized radiation to the site. When considering re-irradiation, the interval of her prior radiation is very important. So if someone has an in-breast recurrence just a year after completing primary treatment, we're more pushing towards mastectomy. In the setting where there's a longer interval, and this could be, again, a new primary tumor, or we could feel a little bit more comfortably doing this. Although in those instances, again, genetic testing and why is this patient developing multiple cancers should be considered.
Thanks. So let's move to the second variation on the theme of local regional recurrence. This time the patient has a very large tumor at the time of the local recurrence in the breast and is treated with mastectomy. There's a 6.5 centimeter area, grade 2 ER/PR positive, HER2 negative with ductal and lobular features, skin involvement, isolated tumor cells in one sentinel node. The question is posed with regards to, would you perform additional axillary surgery? Would you re-irradiate? So I'll ask you both, Dr. Mamounis and Buchholz, to comment again.
So assuming this is the patient that had the prior axillary dissection, right? And now she had a sentinel lymph node biopsy that saw isolated tumor cells. I mean, I would not be inclined to try to perform another axillary dissection if assuming that when you did the sentinel lymph node biopsy, you did not palpate any other abnormal lymph nodes and there were no other sentinel nodes. I would probably rely on the radiation oncologist to then, you know, reduce the risk of local recurrence. And with isolated tumor cells, typically I would not do that.
Dr. Buchholz?
Yeah, this is a challenging case because again, she has higher risk features now presenting either with a T3N1 new cancer or a local regional recurrence that's also recurring in the lymph nodes, both of which make me concerned about subsequent risk of local regional recurrences. Usually for people with intact breasts who have an intact breast recurrence, and are treated with mastectomy, we tend not to use radiation again. The higher risk situations where you have a recurrence after having an initial mastectomy, and sometimes those are the challenges where we do want to be more aggressive in local regional. So in this case, I would have to know details of her prior radiation treatments with involvement of lymph nodes. Now, even if she was just treated previously with intact breast radiation, there's going to be lymph node regions that I'd want to target with radiation that are outside of her previous field, like the supraclavicular fossa, for instance. So that's an area that you wouldn't want to treat twice because of brachial plexopathy and other normal tissue consequences. So we'd have to really review her previous radiation history. And then, as I mentioned previously, the timing or the interval between one course of radiation and the second course of radiation. So with these high-risk features, I would be considering using radiation again, but it'd be highly dependent on careful analysis of her previous treatments and weighing out the risks and benefits with the patient.
Before we move off this variation, I'll assume that a tumor this large would have been picked up on imaging and perhaps physical exam. Dr. Gratishart, is this a patient that you would have offered neoadjuvant treatment to?
So with a tumor this large, even though she is ER positive, it would have been, you know, again, it would depend partially on what the patient's interest was. You know, obviously how big her breast is compared to the tumor, and recognizing that you're not likely to get a PET CR. But if the goal had been to salvage your breast, then chemotherapy could have been considered.
Mm-hmm. Let's move to another variation. If the recurrence had been in the axilla only, how should we sequence therapy? What type of systemic therapy should she receive, and how would you manage the axilla? So since the question about systemic therapy is posed first, I'll ask Dr. Gratishart to comment.
Yeah, I think if she had, again, a recurrence principally evident in the axilla, you know, we would, you know, give some consideration to systemic therapy. And of course, you know, it would have to take into account what she'd been exposed to before, et cetera, if there had been any other prior therapy. But I think it could be a consideration to see what a response was.
Dr. Mamounis, the axilla question.
Yeah, so I mean, I think in this case, we'll probably have to do surgery to remove the lymph node and any other abnormal lymph nodes in the axilla. Again, what you do after, I agree, you know, but if you look at the CALOR trial, you know, showed some benefits from adjuvant chemotherapy, but it was mostly in the AR negative cohort, not much in the AR positive cohort. So you probably most likely sequence it with endocrine therapy and radiation if you can. But yeah, I would typically remove, enlarged lymph nodes either after neoadjuvant chemotherapy or upfront in such case.